Hi friends, welcome to this video on acute bronchitis and chronic bronchitis and COPD. Risk factors for COPD include cigarette smoking, occupational dust and chemical exposure, environmental tobacco smoke, and indoor and outdoor air pollution, nutrition, infection, and socioeconomic status. Acute bronchitis, cough, one of the most common symptoms in daily practice. When consistent for 3 weeks or less, with or without sputum, it is consistent with diagnosis of acute bronchitis. Less than 3 weeks, with or without sputum. Acute bronchitis is a shorter illness that commonly follows a cold or viral infection such as flu. Acute bronchitis usually lasts few days or weeks. Chronic bronchitis is characterized by persistent mucus producing cough on most days of month, 3 months of a year for 2 consecutive years in the absence of secondary cause of cough. Acute bronchitis should be differentiated from common cold and acute exacerbation of chronic bronchitis, asthma, and community-acquired pneumonia. Acute bronchitis is self-limiting and resolved within 10 to 14 days. A non-bacterial cause is present in more than 90% of acute bronchitis. Viral more than 90%. Most common viral isolate based on age less than 1 year RSV parainfluenza, 1 to 10 years parainfluenza entero RSV, and more than 10 years influenza RSV parainfluenza. Not infectious, chemical and fume exposure not well studied, and bacterial 5 to 10%. The only isolate source to cause acute bronchitis are chlamydia, pneumophila, mycoplasma, bordetella, and there is no evidence that S pneumonia and H influenza cause acute bronchitis in the absence of lung disease. So, how the acute bronchitis patient present? Fever, cough with expectoration, and retrosternal discomfort. On examination, few rhonchi and crepitations, which are bilateral. Goals of therapy: first, to do no harm and rule out serious illness like pneumonia and minimize symptoms and limit the use of unnecessary use of antibiotics. Cough less than 3 weeks with or without sputum, signs of consolidation or airway obstruction or fever, increased respiratory rate or a heart rate. If it is yes, consider pneumonia, asthma, any other pulmonary disease. If it is no, during documented outbreak of influenza or pertussis. If it is yes, treat as appropriate. If it is no, it is case of acute bronchitis. Establish expectation of up to 14 days duration of cough. Educate regarding lack of evidence for antibiotic and encourage increased fluid intake, humidity, and recommend antibiotic analgesic antitussives for symptom relief. Investigations: physical examination, absence of tachycardia more than 100 beats per minute or tachypnea more than 24 beats per breaths per minute or fever. Oral temperature more than 38 degrees centigrade and localized chest findings suggest pneumonia. These are all findings which are absent in acute bronchitis. Objective measures: no routine X-ray or viral culture or sputum culture or gram staining is needed or spirometry is needed. Therapeutic choices: non-pharmacological include limit the risk of inoculation and transmission by applying strict hand washing technique, and increase fluid and humidity may help to reduce the cough. Analgesics like aspirin, ibuprofen can be used for symptomatic relief. So paracetamol can be used, ibuprofen can be used, but we have to be cautious with hepatic impairment in case of aspirin, and in case of ibuprofen, peptic ulcer disease or intolerance, any urticaria with the ibuprofen, we have to rule out. Next is bed rest, steam inhalation with Vicks and Benadryl expectorant cough syrup, 2 teaspoons TDS we can give, and bromhexine tablet 8 mg TDS for 7 days. So antitussives may give short symptomatic relief, but doesn't shorten the duration of the illness. Antitussives poured in dextromethorphan. These are all given children more than 12 years. And pharmacological, next is bronchodilators. Use is not supported in the absence of airflow obstruction. If it is airflow obstruction, you give bronchodilator. Adult with cough and wheezing may benefit from treatment. Salbutamol metered dose 100 or 200, 1 puff 3 times to 4 times. We can give maximum up to 800 units per day. Adverse reaction with these drugs include tremor, restlessness, palpitation, headache, And caution with other symptomatic agents are contraindicated in arrhythmias and hypertrophic obstructive cardiomyopathy. Amoxicillin usually given, but it's not indicated, even though most cases are viral origin. And teriflunin, if patient complains of dyspnea, we will give. Treatment is only supportive in majority of acute bronchitis, and patient satisfaction is not related to receiving antibiotics, but quality of pharmacist-patient communication. Indicate regarding the lack of evidence of antibiotic use. No evidence support the use of oral or inhaled corticosteroids. So not needed. No evidence. If there is a dyspnea and a severe breathlessness, we can consider. Set patient's expectation of 10 to 14 days of cough, and mucolytics and expectorants have failed to show significant benefit. If patient shows no improvement in 2 to 3 weeks, consider follow-up. Next is chronic bronchitis. Chronic bronchitis is damage to airways caused mainly by the chemicals like cigarette smoking, industrial gas, motor vehicle exhaust. Persistent productive cough, there is put for at least 3 months in at least 2 consecutive years without any identified other causes. Importance include it may progress to obstructive lung disease and resulting car pulmonary, and it can cause metaplasia, dysplasia, and carcinoma. Chronic irritation, which causes hypersecretion of mucus and hypertrophy of submucosal glands in trachea and bronchi, and marked increase in the goblet cell in the small airways. Why the small airway is obstructed? Because of excessive mucus. Cigarette smoking will interfere with ciliary motility and damage the epithelium and inhibits the alveolar leukocytes to clear the bacteria. So bronchial injury or infection or hyper secretion of mucus or bronchospasm will cause reversible obstruction in case of bronchitis and bronchioles and small bronchi, which cause chronic bronchitis with continued and repeated infections and continued repeated injury. And destruction of alveolar walls occasionally with respiratory infection is reason for emphysema, with continued repeated infection will cause chronic bronchitis and emphysema. Most of the patients, these are all co-indicated. Exist both like chronic bronchitis and emphysema. They exist in most of the cigarette smokers. Hyperemia and edema of the mucous membrane and excessive mucus or mucopollen secretions in the epithelial layers will be seen. Symptoms of chronic bronchitis is cough with expectoration of long duration of at least 2 years. Auscultation has revealed widespread bronchi and basal cramps, and prolonged expiration is diagnosed, and clinically it is chronic bronchitis. Fever usually absent except in exacerbations. X-ray shows prominent bronchiovascular markings. In this image, there is goblet cell hyperplasia along with thickened basement membrane, and there is increased mucosal gland hyperplasia and squamous metaplasia. So, persistent productive cough over the period, patient develops dyspnea on exertion. With further progression, patient develops hypercapnia, hypoxemia, and mild cyanosis. They may land in emphysema. And long-standing cases, car pulmonary and cardiac failure and death may occur. If any patient comes in acute exacerbation of this chronic bronchitis, we give steam inhalation with Vicks 3 times and tablet bromhexin 8 mg TDS for 1 week. If there is dyspnea, give tablet salbutamol 2 to 4 mg TDS for 1 week, or tablet terbutaline 2 to 5 mg TDS for 1 week. Capsule amoxicillin 500 TDS 7 days if patient doesn't respond, or cephalexin 500 PDS or cefuroxime 50 mg PD or acitro 500 mg OD. Tablet prednisolone 10 mg TDS if there is a bronchospasm. Once acute episode over, avoid the possible irritants, no smoking, tablet doxycycline 100 mg, one tablet daily from first to fifth day of every month, and educated patients can be given 15 capsules of amoxicillin to be used whenever sputum becomes purulent. Difference between emphysema and chronic bronchitis. Emphysema is alveolar wall destruction, irreversible enlargement of air spaces, and distal to terminal bronchioles without evidence of fibrosis. Whereas chronic bronchitis Productive cough for a period of 3 months for at least 2 consecutive years, absence of any other identifiable causes, and there is excessive mucus production in the bronchioles and terminal bronchi. COPD onset is in midlife, symptoms slowly progressive and long smoking history and dyspnea during exercise and largely irreversible airflow limitation. It is not reversible. Whereas asthma occurs early in childhood and symptoms vary from day to day, and symptoms at night or early morning are more. Allergy or rhinitis and eczema also present, and these are all other causes of eczema or atopic dermatitis are usually associated with asthma. And family history of asthma will be there, and largely it is reversible airflow limitation. Recurrent obstructive airway disease, bronchial asthma, seasonal or recurrent, and cold is irreversible. Chronic bronchitis and emphysema are combination of both. So, whereas emphysema clinical features include severe dyspnea, cough after dyspnea, and scanty sputum, whereas chronic bronchitis sputum will be copious and purulent and less frequent infections, and terminal RF emphysema and PaCO2 35 to 40, PaO2 65 to 75, hematocrit 35 to 45% increase, and DLCO is decreased, and carpulmonary is rare. Whereas with chronic bronchitis, it is copious, mucus purulent, and frequent infections and repeated respiratory insufficiency. PaCO2 50 to 60, PaO2 45 to 60, hematocrit 50 to 60%, and the DLCO is not that much decreased, and carpulmonary is more common in chronic bronchitis. Chest X-ray shows hyper expansion of lungs associated with chronic bronchitis and COPD. The bronchovascular markings, cardiomegaly may flatten out the diaphragm, and chronic bronchitis with irregular pattern of bronchovascular structures. Chronic bronchitis and the lines that leave the right hilum horizontally shows irregular borders because of chronic inflammation. COPD with hyperinflation and flattened diaphragm and pulmonary arterial hypertension. Emphysema causes dilation of air spaces by destruction of alveolar wall leading to collapse of alveoli during expansion. Emphysema increased air space with destruction, and overinflation increased air space without destruction. So there is alveolar enlargement because of interstitial tissue loss with destruction of elastic tissue. Clinical picture in case of emphysema include dyspnea, cough with or without expectoration, wheezing, loss of weight or peptic ulcer, and hypercapnia, changes in the central nervous system, and barrel chest. Thin dyspneic patient with decreased vital capacity and increased lung volume, feature of thin coughers. Whereas chronic bronchitis is obese with psychosis. Predominant bronchitis 40 to 45, predominant emphysema 50 to 75. Dyspnea is mid or late in case of bronchitis and severe in case early and in case of predominant emphysema. Cough is early copious sputum in bronchitis, whereas late and scanty, and respiratory insufficiency repeated in predominant bronchitis and terminal, and carpulmonary is common in bronchitis, whereas rare in terminal cases we see in carpulmonary emphysema, and airway resistance increase, normal or slightly increased in case of emphysema. Prominent vessels and large heart, and hyperinflation at small heart is seen in predominant emphysema, and appearance blue bloater and pink purple. Treatment of emphysema include TO 9 microgram inhaler, 2 puff OD with 0 stat, VT spacer, and 4 cart 200 microgram inhaler, formoterol plus budesonide inhaler, 2 puff PD, and epinephrine 100 mg PD, good physiotherapy, and a high protein diet. Apart from that, smoking cessation also there. What are the general measures we will advise in case of COPD and emphysema? Must stop smoking, otherwise lung function deteriorates. Deep breathing exercise 20 times, 3 times a day, and regular mild exercise to keep healthy and avoid exertion. In severe cases, use walking aid or wheelchair to avoid exertion. Vaccination, influenza vaccine given every year, pneumococcal vaccine 13 V start, and PPSV after 1 year, and repeat 6 yearly, and Tdap if never taken previously, and recombinant zoster vaccine 2 doses we have to give. If and when there are bronchi, use inhaled bronchodilators. Aspirin 1 to 2 puffs 3 to 4 times a day, or ipraven 1 to 2 puffs 3 to 4 times a day. If not controlled, regular use of inhaled corticosteroids. Glycerin inhaler 100 micrograms 1 to 2 puffs or 1 to 4 times a day, and derifilin 150 milligram OD, or antibiotic if foul expectoration or fever is there. If there are more than 2 exacerbations per year, give LABA plus steroid, long-acting beta analog, along with steroid, Seroflow, salmeterol plus fluticasone, 1 to 2 puffs BD, or Foracort, formoterol plus budesonide, 1 to 2 puffs BD. For maintenance therapy, TO inhaler, 2 puffs or Rotacap, 1 daily, and tap terbutaline, 60 milligram TDS to increase tissue. Terbinafine, not terbutaline, it is terbinafine, 60 milligram TDS to increase tissue oxygenation. If there is acute exacerbation, give cephalong DS1 PD for 5 days and nebulization with aspirin or Budicort and injection daily IM or IV star. If chronic productive cough is there, we can give mucolytic therapy, nebulization with mucomix solution. If there is excess mucus production, mucomix solution, we can give with nebulization. Serious COPD and advanced emphysema treat under guidance of physician at high dose of long-acting bronchodilators and steroid inhalers given by a spacer. Seroflow or aciflow inhaler 1 to 2 puffs with spacer 2 to 4 times a day, and keep the nebulization with aspirin, TDS and SOS, and TO inhaler 2 puff or Rotacap 2 times daily, or Tiomet inhaler or Rotacap twice daily. Tiomet include tiotropium and formoterol. Arrange for oxygen cylinder concentration at home if hypoxic, and oxygen mask for 4 to 16 hours per day, and injection derifilin 2 cc AMA or SOS, aminofilin 10 cc IV slow for severe breathlessness. And if there is leg edema or call pulmonale, we can give lesilactone of 50 milligrams OD, or Cardace 1.25 milligram OD. If not controlled, refer to chest physician or ICU. Advanced COPD treatment include non-invasive positive pressure ventilation for 1 to 3 weeks, and lung volume reduction and lung transplant. Thank you.
And Napoleon Hill called this the master key to riches. After studying 500 of the richest people in American history, it is the quality of self-discipline. It's the ability to make yourself do what you should do, when you should do it, whether you feel like it or not. This persistence is self-discipline in action. Every time you persist, you build your self-discipline. Every time you practice self-discipline, you build your ability to persist. And the two of them are tied into your self-esteem. So the more you persist, the more you like yourself. And the more you like yourself, the more discipline you have. And the more discipline you have in practice, the more you like yourself. As a result, the more you persist. You reach the point where you know you can achieve the goal and nothing in the world can stop you. We're living at the very best time in all of human history. More people are going to become millionaires and are becoming millionaires today at a faster rate than we've ever thought possible.